Okay, yeah, so thanks for joining us. So my name is Robert Smith. I'm a director health economics at Peak Analytics. My background's in public health economics with a PhD from University of Sheffield. I worked at the UK Health Security Agency during the pandemic, and then I'm also director of the R for HTA consortium, essentially trying to move the industry for drug technology assessments, health technology assessments from Excel to R. I'm probably best known for applying these methods from data science to improve decision making. So I've just kind of spent the last 10 years sort of banging that drum. And I'll hand over to Oliver to introduce himself.
Hi everyone, nice to meet you. I'm a data scientist at Peak Analytics. I've been working with R for 2-3 years, and more recently at Peak working on health economic models, both the back end and also the front end, so shiny dashboards to interact with those models. And most recently been working pretty heavily on the work that we're going to show you today about geospatial access. So I'll hand back to Rob to get into things.
Okay, so just to provide a bit of background to this project. So a few years ago, back in 2019, we did some work with Parkrun, looking at where to locate new parkrun events. So for those of you who don't know, Parkrun are a weekly 5K running event on Saturday morning that take place in parks all across the UK, and the world now. And so what we were looking at is how to identify green space sites, so local parks, that could be a good place to locate a new event to improve or increase the amount of runs that take place or improve access the most for certain communities. So either the entire population of England or kind of weighted more towards more socially deprived communities to improve access for them. We did that work in a whole series of publications resulting from that, and a whole series of presentations that we gave, and you can look at those on our public talks page, and that sparked interest recently about applying the same principle to access to healthcare, and so what we were interested in is how we got, it's just a little bit on the screen. Yeah. So we're basically looking at which treatments patients will pick or be provided based upon their location and their access to treatment centres, and then also understanding how distance to care influences adherence as well. So there's evidence across a lot of different conditions, so cancer, HIV, depression, among others, that of course if you live a particularly long distance away from a treatment centre, you may find it more convenient to select one treatment or another. So one obvious example is the difference between oral versus subcutaneous or oral versus IV. There might, if you have a 200-mile drive to go have your subcutaneous administration, but there's an oral option, then of course that trade-off might be weighted differently than if you have a 5-kilometer drive. And so with that in mind, we wanted to make sure that we could understand how this differences in access contribute to differences in health outcomes, with the assumption that imperfect access results in poorer outcomes and higher healthcare costs, and improving access therefore benefits patients, providers of care, and payers. And so that's kind of the logic flow for this piece of work. In terms of the challenge, so we wanted to quantify and understand where gaps in access exist, and how we can prioritize new sites for maximum benefit. So if we have to select from a whole load of healthcare sites, which ones should we select based upon where they are located? And so we wanted a scientifically robust and a reproducible framework that we could use, that could be updated over time to understand kind of the logic and the quantitative framework around the selection of those sites. So to do that, we've gathered data from a a number of different data sources, ranging from NHS England on sites and locations, open source mapping software to map distances between sites and where people live, so lower super output areas, which we'll cover in a minute, and then data on population demographics used to estimate prevalence. And we've then modeled these outcomes in the R programming language with bits of C++ to speed things up, and built a user interface dashboard that Oliver's going to show in a minute to allow users who aren't familiar with running kind of programming software to interact with this in a nice, intuitive way. And so the aim is to be able to guide decision makers, be that from industry, from NHS England, and also provide information to different patient groups, for example, who might be interested in how they could have improved access and understand which potential sites might be beneficial. So if we think about the objectives, so the first objective was to measure access to care across England. That's kind of our first descriptive piece of work, just how good is access in different regions of the country, and does that vary by deprivation? So do more deprived communities have worse access or better access? So it's purely a descriptive piece of work. And then we wanted to estimate how improving that access by adding new sites would influence our key outcomes of interest. So that's things like adherence, and therefore, by kind of extension, improved health outcomes. And then we wanted to understand exactly where should these optimal new locations be from a list of potential candidate sites. So you might imagine that this principle could be applied to a list of candidate NHS trust sites, or it could be applied to a list of candidate GP practice sites, depending on the mode of administration and the disease area that we're talking about. So there's kind of the primary objectives. There's a lot of different perspectives for this piece of work, and there's a lot of overlap. Ultimately, different stakeholders are pulling in the same direction, but obviously from the NHS perspective, the NHS is going to be particularly concerned with NHS capacity and resource use. Patients may be more concerned with convenience and out-of-pocket costs. Industry might be concerned with revenue, and then there's kind of objectives that overlap a lot. So things like the equitability of coverage, the availability of treatments, and then ultimately patient outcomes. So, and then there's this wider framework where societal outcomes might be of interest. So particularly around environmental impact and economic productivity that have kind of wider ranging outcome effects. So I'll hand over to Oliver to carry on.
Thank you. And I'm just going to apologize about my choppy slide transitions there. All right. I'm going to go through the data and analysis framework that we used for the project. So I won't go into a ton of detail about the data inputs because I think Rob's covered them. So I'll go through briefly. But first of all, just need to cover the idea of lower super output area, which many of you may already be familiar with, which is a small geographical region defined by the Office of National Statistics that has a population of around 1,000 to 3,000 people. And this is about as granular as the data we needed that we could find released open source about things like population demographics, like index of multiple deprivation, and then also age, sex breakdowns, things like that, which were useful for trying to predict disease prevalence in these small regions. So we got this data from the Office of National Statistics, information about where trusts and GPs were from the NHS, and then also relied on open source map data and open source routing machine to actually calculate possible travel distances between small LSOA regions and existing sites. So the kind of process that we go through is when working on this is first to identify where patients are, and that's through sort of trying to estimate the prevalence within small LSOAs based on the demographics there. Rob will talk a little bit more about that later. Then placing where the current sites are located based off of kind of postcode information. Then given the location of kind of where we estimate patients to be within LSOAs and where we know sites are, provide some estimate of kind of current outcomes. So things like the distance that patients have to travel, what's their travel time, or estimating things like treatment administration costs or out-of-pocket costs for patients. And then to understand how we could best improve access, we go through this systematic process of trying to estimate what the outcomes across patients would change to if particular candidate sites were included. So in this little scenario, patients are switching to a closer candidate site, and we kind of repeat this process systematically, depending on the outcome that we're looking at. So this is the process here. So we start by taking an outcome. So let's say the simplest, kind of most straightforward outcome we could look at is travel distance. And then we have a existing set of potential sites that we're interested in understanding, okay, which of these set of sites is the most promising for improving this outcome. So we calculate the distance that patients would have to travel from every LSOA to every candidate site. And then we assume basically that patients are always going to switch to a closer site if that site were available. So we look at saying, okay, if we just built this one candidate site, how would patient travel distance across all of England change? And normally that's just going to be a small number of patients in the small region around the candidate site, but then we estimate the change across all patients. And then we select the candidate site that improves the travel distance the most. We add it to the set of existing sites, and I'll talk a little bit more about why we do that later on. And then we repeat this process each time selecting the candidate site that improves the travel distance the most. And then at the end, we have a list of candidate sites. So I'll go through and show kind of a simpler example to really illustrate what this process is, using a very kind of icon-y pictorial example. So if we treat each of these little squares as like an LSOA, and then these little dots is what's called the population weighted centroid of the LSOA. So that's basically the average location where people are living within the LSOA. And another way to think about that is just taking the average of the X and Y coordinates of all of the people living within that LSOA. So what we do is we start by estimating the current distance that patients are traveling. So in this scenario, we're trying to optimize the travel distance that patients travel. And then we look at what would happen if we included site B and then site C, and we add up those distances, figure out which one minimizes the total distance traveled, and then add that candidate site B to the set of existing sites. And the reason why we add that site to the set of existing sites is to prevent site clustering. So if there was another candidate site D next to B, and we just removed B from the set of candidate sites after we'd selected it as being very promising, it's likely that the next selected site would be D because it occupies a very similar position. But we're more interested broadly in areas where it would be useful to improve access by adding a site, not very specific tiny sites within that. So if there are 5 sites all within a small region that are promising, you can think about maybe GP offices or pharmacy locations. We really are only interested in knowing, okay, it would be useful to add a site kind of in this town center or in this town. And then we want to know where's the next best town, not what's the next best pharmacy within that small region. So that's kind of why we add B to the set of existing sites. So once we've done that, now we repeat the process having included B. And in this case, because we're looking at travel distance and patients are always going to switch to a closer site under our assumptions, there's no way that adding a site can kind of affect outcomes negatively. But for other outcomes, this might be the case. If you look at, I don't know, something like treatment administration costs, where adding a site maybe drives more patients to use that site, but then actually increases costs. So, but in this scenario, adding in the new site only improves outcomes. So Adding in site C reduces the distance traveled slightly, and then we get a set of greedy search results. So in this case, we've used a pretty simple objective function, just try to minimize the travel distance. But this generalizes and could apply to other outcomes like one I mentioned was NHS costs, which is our treatment administration costs, or something like patient out-of-pocket costs, whatever you're interested in, and have a good way of calculating, a reasonable way of calculating. Right. So in practice, this isn't just occurring on this tiny scale like you've seen, but across, there's like 30,000 plus LSOAs in England, and we considered hundreds of candidate sites, but this can quickly scale up to thousands of candidate sites if you're looking at GP locations, and even more if you're considering pharmacies. So it's a big map. There's a lot going on. All right, I'll hand back over to Rob to go through some of the methods.
Yeah, that's great. So I think that's covered the kind of core process with the greedy search algorithm. If you go to the next slide. So in order to inform kind of the weightings of each LSOA, so each small population centroid, we combined demographic and prevalence data for a given condition. So it could be HIV or MS or whatever the condition is. And we combine that to estimate the expected number of patients per small geographic area, so per LSOA. So we have all these small LSOA centroids, and for each one, we're estimating what is the expected number of patients in that LSOA. We then also combine that with a calculation of travel times. So what we did was to take each of these small LSOAs and calculate the travel time and travel distance between those 33 LSOAs and every possible service delivery site. In this case, because we were looking at roughly 200 to 300 sites, there were 6.5 million combinations, distances that we needed to calculate. So we used an OpenStreetMap and open source routing machine, basically ran that on Amazon Web Server and compared by cross-checking against travel times and the Euclidean distance. So on the next slide, we can see that there's the distance versus the duration. So you can see these are very strongly correlated. Locations that are further away take longer to get to. And we then looked at what's the distribution there of that relationship, and therefore what is the assumed speed at which people are traveling. And you can see here that generally that falls in a range that is credible, especially for driving. So generally most of the travel is occurring in our calculations at roughly a speed of 50 miles per hour, which kind of makes sense when you think that a lot of these distances are really long. So we've calculated the distance from the borders with Scotland all the way down to, say, Plymouth, and so most of that travel time would be on a motorway. We also then look at the relationship between distance and adherence, and this is just a placeholder chart here, but just to show that if we know that there are 3 treatments and those different treatments have a different uptake percentage, so these all sum to 1, so there's some probability that that an individual would initiate and adhere to treatment A when they're really close to a site, but then as they move further away from a site, they are less likely to either initiate or adhere well to treatment, whereas treatment C is much more likely to be chosen if you live further away. So again, going back to my previous example, there's certain treatments or options that might be more preferable if you live further away, and there's others that might be more preferable if you live much closer to a site. This is the part of the project that we are most it is kind of most difficult at the moment. Understanding these relationships, there's very little published literature on this, so this is something that we'd love to get back on. So yeah. And then going through to the calculation, if we go on to the next slide, essentially we're taking all of this information, the greedy search process that Oliver mentioned around identifying sites, the information we have on the prevalence, so where people live who have the condition, and then combining that to calculate things like NHS costs, patient productivity loss associated with traveling, and patient out-of-pocket costs associated with travel and things like parking, etc. We can also look at the number of treatment administrations given initiation and adherence for different types of treatment. And we can also look at environmental outcomes like CO2 emissions from travel. Because of course, if we're bringing things closer to home to people, people have to travel less distance, and therefore there's less CO2 emissions. Okay, so this is probably the most interesting bit. So I'm going to hand over to Oliver, who's going to demo the app. So just while Oliver loads that up, what we've done is taken all of this analysis and these algorithms and run them on a remote server and built a user interface for the front end, so that a user who's not a programmer can play with the tool, run the algorithms live for their given condition, settings, region, objective function chosen to make it more usable. So as a company, this is kind of what we primarily do for modeling work, and just trying to engage stakeholders in that way.
Can everyone see that? Great. Okay. So this is the sorry. This is the app, and I'll walk you through first, going through some of the selections on the sidebar here, and then we'll go through the different tabs in the main panel. So first, because this method is kind of applicable across diseases, we have the ability to kind of select multiple diseases built in. Right now, this isn't doing anything, but more just to show that this is a method that is applicable across disease areas. And I will emphasize there's no, this is all kind of dummy data in here at the moment. So don't lean too heavily on the outcomes. Yeah. So we have within here first, you kind of would select disease of interest, and it's probably easier to see on the map. Switch this over. So we have the locations of what we've assigned to be existing sites, which are some NHS trusts in red, and in blue, what would be candidate sites, so considered as kind of maybe not providing a particular treatment, but could possibly be providing a treatment. And the idea is that someone interested in understanding where the best candidate sites are would first pick the disease they're interested in, then narrow it down to the specific region where they are interested in understanding what the best site locations would be. So right now this is set to be all of England, but we could select specific areas like London and the Midlands, or London and east of England, but I'll leave it on all of England for now. Then they'd pick what strategy they want to use to, really this is better described as what outcome they want to maximize. So right now we have travel distance and travel time, but we can include other outcomes as well, any of these outcomes that are displayed here. And I'll hop back to this tab in a minute. And then the number of candidate sites that they're interested in ranking. So let's say we'll look at 10 this time just to keep it simpler. And then they run the search. So the search happens live. So we haven't run the searches already because there's kind of combinations that we just allow them to run it in the app. And you can see kind of the locations popping up on the map ranked as to where the best locations for sites would be. And this is weighted by this is weighted by patients. So for each LSOA, we're calculating the distance to a particular site and then weighting that distance traveled by the number of patients in that LSOA. So if I hop back to the headline tab, we can see the impact on all of these different outcomes of building those candidate sites, and the change in the outcome from before the candidate sites were considered built. We can see a breakdown by IMD quintile. So this is the IMD quintile that patients belong to from the broader population, not taking all of the patients and then splitting them into quintiles, but more figuring out which quintile they already belong to in the broader population. And we can see the impact across quintiles on different outcomes. So things like travel time. And you can see there's a variation in the travel time, most likely because there's a lot of deprived regions within cities where people travel less. But you can see that the kind of reduction across quintiles is pretty similar in this case. So heading back to the map, one thing to point out is that it's probably rare that someone would be able to build all of these candidate sites at once. So they might be interested in understanding the impact on outcomes of just building specific sites, or they might know, oh, this site's probably easier to build, or site 2 is probably easier to build than site 1 for whatever reason. So we have this table here that allows people to explore the impact on outcomes of just selecting particular sites as kind of being included in the set of existing sites. So we could just look at site 2, or what about site 2, site 4, and site 7. So all that kind of allows people to further explore the results. An additional thing to show here on the map, I'm going to just hide some of these, make it easier to see. So we have a heat map of the expected prevalent population. This is something that can be updated for particular NHS regions. So if we just consider kind of London, and then let me see, that's not updating. That's right. There we go. So we could kind of update the prevalence within this region by sort of scaling. If someone had a better idea about the number of cases, because right now we're estimating the number of cases. If someone had a better idea about the total number of cases, say in London, they could provide that as an input over here. And then we would then scale the cases in that region accordingly. Another thing we have on the map, which is useful to look at, especially in the context of this greedy search, is something to help people understand the impact on particular patients coming from a specific area. So if we think about a patient who's already very near to an existing site, the impact of building this site is likely going to be minimal. So we display that here for a particular patient traveling from that LSOA. We have the distribution of patient travel times here, considering the existing sites being built in red, and then the existing sites plus the rank sites. And you can see that for this patient, their travel time isn't affected. So this is the travel time for a patient coming from that region, and their outcomes aren't affected. But if we considered a patient who's very close to one of these sites, one of the candidate sites is being built, you can see there's a massive reduction in the distance that patient has to travel, the time that patient has to travel. You can see that quantified here and then also displayed on the site. So this kind of feature was included to help emphasize, people, especially on the tail end of the travel time distribution, see a really big impact on their experience as a result of building new sites. The final thing to show is the settings, which I already briefly showed here. And all of these can be updated. So these are all of the parameters for the outcomes you've seen here throughout the app. And all of them are kind of dependent on these values, so we can update them live and then revisit them. So for example, take the patient out-of-pocket cost. So if I reset this, the patient out-of-pocket cost here is £25, and we can update, let's say, the cost per kilometer traveled to £1, and then update that in the app, which will update all of these kind of underlying LSOA traveling to this existing site or this candidate site calculations for these outcomes, and we can see the out-of-pocket cost has jumped up. So I think that's everything for the demo. So I'll hand back to Rob. Is that sharing the slideshow?
Yep. Yeah, that's great. Okay. So I think that probably has done much more just demoing that than explaining did. But so on to the next slide. So just to finish up, in terms of the things that went well, things that we think as kind of strengths of this approach. Obviously, it's very data driven, so we've got good data on LSOAs, on things like demographics and deprivation and all of that kind of thing. It's generally quite easy to get site locations, so we can get that from the NHS in terms of trust locations and GPs and pharmacies. The mapping software is all openly available, so all of that kind of thing is very easy to reproduce this analysis. There's a lot of structural flexibility, so I know a lot of time geospatial work is done with proprietary software, but obviously that means that it's kind of everything's like click and drop, and if you wanted to build in a custom component, it can be quite tricky. So because this is just programmed in R and C++, we can kind of adapt it as we need, and other people can build on it. The user interface obviously means that it's kind of stakeholders can engage with it. Otherwise, it would be almost impossible for most decision makers to engage with. And there's obviously very specific insights. We're making some of the components open source, especially around the mapping and the greedy search algorithms. So there's kind of a research benefit there as well. And hopefully other people can build on it and critique what we've done. In terms of the limitations, so currently travel is based on driving distance. So we've not driving distance and driving time. So we don't currently have public transport networks in there. I think that would be really useful for cities. There's no kind of behavioral validation yet. And really the thing that we're lacking or need more of is the evidence on adherence by distance. I think that's kind of the really big next step. We've got some assumptions in there that we've worked with various clients on based upon their understanding and experts' understanding. But really, like, data is quite limited here, so it would be great if we could be directed to more literature there. Anything that's an at-home service, of course, this is kind of more applicable to services that are administered, say, by a healthcare professional at a site that somebody has to travel to, a patient would have to go to. Things like if patients do their own subcutaneous injections at home, then of course they just get sent out by mail, so this becomes less relevant. So we really are focused on treatments requiring visits to healthcare sites. And the last one, which is not really a limitation of this work, but more just kind of a next step, is that this is purely quantitative. And so it'd be really nice to find qualitative insights to kind of augment and tell the story. And so really kind of understanding what this means to patients will be really useful. And so the hope is that we can engage with patient groups to really kind of augment the story around certain conditions and what that means qualitatively. But yeah, that's what we found with the parkrun work as well, is we had this initial quantitative layer to understand certain areas that were missing parkruns. But then what happened from there is we provided the quantitative analysis, and then the team on the ground took that kind of list of potential new sites and then worked with stakeholders within that small geographic area to then understand, okay, so are there any qualitative considerations that we need to think about around the specific park not being suitable or anything like that. It would be much the same here, where this could be the first step that then leads to discussions around which of the sites that are identified as being optimal are kind of suitable for other reasons that we may not be aware of within this analysis. So going on to I think the final slide. So key takeaways. The main one is that that obviously having a tool like this can help highlight these inequalities, describe the current situation, and then provides a framework that's kind of ready for adaptation to answering questions around optimal service sites and provision. So it really is a kind of an initial prototype that's being used in a couple of locations now, but is mainly a prototype to show the concept, and then would have to be adapted for specific questions. So thank you very much, and we'd love to take questions.